It's time now to invite the last speaker of the session. I know we all have been waiting for him to speak. He certainly doesn't need any introduction. Dr. SRI GANESH is the chairman and medical director of Netradhama Group of Eye Hospitals, a prolific, frequent refractive surgeon, internationally renowned, a great mentor, teacher, and innovator who has always been on the forefronts of the technology and is a role model and favorite for people from all generations. Sir will be talking on a new on a new latest ASOCT based tomography system, which is the MS39.
Can you bring up?
And its advantages in clinical practice.
Can you bring up my presentation? It's there. Good morning, dear friends, and I would like to thank Dr. Sheetal for inviting me to her course on the refractive toolbox, and it's very nice to be among my fellows, I think all of them whom I have trained over the years, and presenting in this IC. So I'll be talking about the anterior-segment OCT based tomography, which is the latest device, and what are the advantages in clinical practice. I am a consultant to Carl Zeiss Meditech and Biotech. So let's look at the technology. The OCT based tomographers are the most advanced devices for anterior segment analysis, and the MS39 combines a Placido disc corneal topography with a high resolution OCT based tomography. It delineates the epithelium from the total cornea and gives you epithelial maps, and you get a full coverage of the cornea. It gives you a 16 by 16 millimeter coverage. So even larger corneas, which are like 12.5 mm, you can get a good coverage, unlike other devices like the Pentacam, where you can just image 9 millimeters by 9 millimeters. So let's look at some of the applications. As you know, in refractive surgery, the most important application is to rule out patients who are not suitable for refractive surgery, and that is keratoconus screening. And this was a paper that looked at the accuracy of the indices of the MS39 for diagnosing keratoconus, and they found that it had a very high sensitivity and specificity of more than 97%. So it was able to diagnose keratoconus and also diagnose normal corneas. Now, if you look at the Pentacam, it has got a very low sensitivity, in the sense that the sensitivity is about 67%, especially if you're looking at the bad displays, but it's got a high specificity of around 97%. So basically, the Pentacam has a tendency to overdiagnose keratoconus if you're looking at bad. So even normal corneas, borderline or normal corneas, can be classified as keratoconus in the screening, and so you will miss out about 30% of your patients. You will be rejecting 30% of your patients for refractive surgery, and that is going to affect your income also. But it is very specific in the sense that if it says that there is no keratoconus, then 97% of the times you can be sure that there is no keratoconus, and you can go ahead safely with the refractive surgery. So in terms of safety, it is good, but then you will lose out on a lot of patients on whom you can perform the corneal refractive surgery. So with the OCT based system, both the sensitivity and specificity is very good. So that's why it is a very valuable equipment for diagnosing keratoconus and also for ruling out patients who are not suitable for refractive surgery. So if you look at the indices which are there, it has what are known as the notable points. which it takes into consideration, which is the epithelial thickness, the stromal thickness, the thickness of the cornea, the K-max, and the elevation. And it classifies it as normal, borderline, or keratoconus. Normal, the notable points total to more than 1. And 0.6 to 1 is borderline, and if it is less than 0.5, then it can be an indication that the cornea is abnormal and there can be keratoconus. It has also the other indices like the curvature indices, the elevation indices, corneal thickness, epithelial thickness, and you have a slider, colored slider. So if you look at the color slider and the indicator here, if it is green, that means it is normal. If it's yellow, it's borderline. And if it is red, that means it is abnormal. You also get like a warning triangle here if it is red. So you can know which parameter is abnormal. It also gives you a classification of whether the cornea is normal or keratoconus. And if there is keratoconus, it also gives you the keratoconus morphology, grading of the keratoconus, the ABCD grading, and also the phenotype, whether it's a nipple type, central, axial, or eccentric, and the keratoconus center, the axis of the keratoconus also. So coming to the Gaussian curve maps or the axial maps, they are more sensitive and true morphological picture of the pathology because it's got a placido disc typically, which is very accurate for curvature maps. And it gives the geometric mean of the maximum and minimum curvatures at one point on the surface. So here you get a keratoconus summary map where you have all the maps like the anterior surface, the posterior surface, the epithelial thickness, then the stromal thickness. So it subtracts the epithelium from the stroma and gives you the stromal thickness, and then the total corneal thickness. It gives you the tangential anterior curvature, tangential posterior curvature, epithelial thickness, stromal thickness, again the pattern deviation, and the corneal thickness pattern deviation. It also gives you the anterior elevation and the posterior elevation, and of course all the indices. So in one screen you can get a lot of information. If you repeat the scans with time, you can also get what is known as the keratoconus progression in respect to all parameters like the anterior curvature, posterior curvature, anterior and posterior elevation, and the corneal thickness. And you can see the difference maps here. Over a period of time, if you're comparing two maps, you get the difference map, and which is color coded, and you can actually see whether there's a progression of the keratoconus. The epithelial map is very important nowadays for diagnosis of keratoconus, and I think Dr. Sheetal has covered this in detail. And this is a beautiful paper from Dan Reinstein where he shows that the epithelium has a masking effect, and it thins out over hills and it's thickened out over valleys, and it has a significant effect on corneal remodeling, and you get what is known as the donut sign in keratoconus. So it can be a very sensitive indicator of keratoconus when you look at the epithelial maps, because typically when you look at the pentacam, the teaching is that you have to look at the posterior elevation, and the posterior elevation is more sensitive. And there were even the theory that proposed that the keratoconus starts on the posterior surface of the cornea. Okay, but we know that is not true. In keratoconus, the pathology is in the Bowman's membrane, where there is thinning and fibrillation of the Bowman's membrane and bulging of the Bowman's membrane and the anterior stroma, and this is followed by the posterior curvature changes. But actually what happens is the epithelium kind of compensates for it. So because the epithelium is compensating for it, you don't see the anterior curvature changes early, and you see it more on the posterior curvature. But actually the keratoconus starts on the anterior surface. So when you look at an epithelial map, it is very sensitive and you can diagnose early keratoconus. So this was some examples. This is a 26-year-old female interested in refractive surgery. This is a refraction, a low myopia. And if you look at the pentacam, you can see that it shows a thin pachy, 458 microns, and the bad again is abnormal and shows that it is like a form frustrated keratoconus. And these are typical cases which you may reject for refractive surgery. You look at the bad and you say, no, patient is not suitable, and you can reject. But this is the MS39, which shows a thin pachy for 460 microns, but you look at the classification, it is normal. So what is abnormal here is only the thickness. So it is a normal thin cornea. And these are patients which are not susceptible for ectasia. So you can go ahead, and it's a low myopia. So you can go ahead and do PRK and the patient will do well. So this is another case, 26-year-old male interested in refractive surgery. Again, very low myopia with some amount of cylinder. And he's got a thick pachy. You can see that he's got a thick pachy, 561. But the bad shows a form frustrated keratoconus. If you look at the elevation map, both the anterior and posterior elevations, it shows an abnormality. Though the total score is normal, when you look at this anterior and posterior elevation, you are kind of confused and you don't know whether this patient is suitable, and you may reject this patient. But if you look at the MS39 and if you look at the parameters here, it says the classification is normal. Of course, the elevations are a little off. So sometimes in prolate corneas, you can get a higher elevation. It's not that the cornea is abnormal, but what you need to do is look at the epithelial thickness map. If you look at the epithelial thickness map, there is no donut pattern and the epithelium is perfectly normal. So this is a patient which you can go ahead and safely treat. It also has advanced analysis of the tear film. It's a non-contact assessment of the breakup time. And so with the Placido image here, you can actually look at the reflection and see if there is any abnormality in the tear film. It also gives you a breakup time and a map. So if it's all green, that means it's a normal breakup time. So this was a patient, an example, 25-year-old female who was using contact lenses for 5 years on and off. And this was her refraction, 4.25 with one cylinder. And if you look at her other parameters were normal, but if you look at the tear film, you can see the distortion here on the Placido rings, and you can see the breakup time is abnormal. Okay, both eyes. So then this patient was put on lubricants and then discontinued contact lenses, and you can see after 1 month the tear film becomes completely normal. But what you can also see is that the amount of astigmatism has reduced from 1.5 to 1, and the K reading also has changed. So a dry eye can cause problems in measurement of the K readings. So whether it is for refractive surgery or if you are doing biometry. So it's very important to measure the tear film and look at the breakup time, and this is a good device where you can do a non-invasive screening. It also gives you optical quality analysis summary. So it gives the wavefront and the point spread function. It also gives you a simulation of the visual function and the MTF. So by looking at this, you can know the optical quality of the eye. You can also look at individual corneal abrasions, and it also segregates the total from the epithelial abrasions. So you can look at the epithelial abrasions by itself and you look at the total abrasions, and you can have an idea about the abrasions. It also gives you pupillography, so you don't need to have a separate device where it gives you the static pupillary offset and dynamic pupil, and it shows you the graph like this. So you can see that this is the scotopic 6.37, mesopic, and the photopic 3.73. So you can plan your optical zones when you are doing your surgery. It also can do what is known as dynamic vault assessment, and this is very useful in ICL cases. So I'll just show you how the vault, this is the ICL, and you can see as the pupil constricts, the vault keeps changing. Okay, so you can We also did a very interesting study where we looked at different pupil sizes and the vault, and we saw that there can be a change, and it is different for different phakic IOLs with different materials. And it can also do advanced lens biometry, and it can give you the expected lens equator distance, lens thickness, predicted IOL position. For example, this is a patient with minus 14 diopters, minus 1.5. So you put in the data like the axial length, target refraction, pupil diameter, A constant of the implanted lens, and it will give you the power of the lens to be implanted. This is 10.5 diopters. And it will show you the optical quality also. So this is very useful. This is ray tracing. It also has a software for intrastromal rings where you can look at overlaying the rings depending upon the keratoconus. And it's got a very high resolution OCT of 3 microns. So you get a very nice OCT from limbus to limbus. This is intrastromal rings which are there in the cornea. So to conclude, the MS39 has multiple functions like keratoconus screening, enables anterosegment surgeons for better understanding of their patients, visual issues, and you can also choose the most appropriate treatment for them. And it's a very advanced tool, and I think this is all in one where you have multiple functions, so you don't have to subject the patient to multiple scans with different devices. So one device would do most of the give you most of the information that you need to plan your refractive surgery. Thank you very much for your attention.
Thank you very much, sir, for highlighting the role of newer OCT-based tomography systems. I'm sure there are many more applications. We just need to explore these machines more in detail. So, any quick questions from the audience? The speakers for the next session are already here.
We have 5 minutes, and they gave us the hall 5 minutes late, so actually we have 10 minutes. So if there are any questions, we can take a couple of questions on the various equipment, your refractive toolbox, all the devices which you require to do a good refractive surgery for assessing the patient. So any questions, any doubts?
I can see some seasoned refractive surgeons here, and I can see Rupal ma'am there. Ma'am, just if you could come in.
Yeah, Tanvi is there at the mic. Hello, Tanvi.
Tanvi. Thank you. I'm always very, I learn a lot from your talks. But one thing, you showed some topography scans which had the anterior posterior elevations shown where everything else looked okay. Do you give weightage to the white to white size, the limbus to limbus, white to white? Because that's another
See, white to white is very important, and sometimes what you see is even some of the high myopes, the white to white is smaller. You expect larger corneas, but sometimes they are smaller, and typically they have steeper corneas. Now the K max in these corneas can be 46, 46.5, but they are normal, and typically they are more prolate. So you get this kind of increased anterior and posterior elevation. So it's not necessarily an indication that it is keratoconus, and if all the other parameters are normal, you can still go ahead and do the refractive surgery. I have done many cases like this, and they are
Do you
fine.
have any cutoffs for the white to white? Like less than 12 is what, even though you may see an anterior posterior elevation, you would still go ahead? Or is it, do you not have a cutoff? Like
no, there's no definite correlation, because sometimes, occasionally you see this. Even higher myopes, typically you expect larger corneas, but the white to white is a little smaller and they are steeper. It's not in all cases, so there's no definite correlation, so you can't have like a cutoff as such, but you keep this in mind that sometimes you can have prolate corneas and steeper corneas, but still normal.
Thank you.
Wonderful session. I just wanted to ask two things. One is, if you have to buy only one instrument, one equipment, you think MS39 would be
Yes, I think
giving you most of the information that you would need?
The MS39, I think, is more reliable. It's OCT based, and it also has a Placido. So the Placido is excellent for curvature maps and also for assessing dry eye and the surface. So this has both a Placido and an OCT. The OCT resolution also is 3 microns. So it is a high resolution OCT. So you can also use it for other things like assessing the flap, assessing the interface, which you cannot do with the Pentacam. And the sensitivity and specificity is actually much better than the Pentacam. The Pentacam overdiagnoses keratoconus. So that's why I don't, of course, Pentacam has become the gold standard for whatever reason, but these newer devices actually, I would say, are more reliable, and it gives you everything. It gives you white to white, it gives you the pupil size, it gives you tear film. So it gives you a lot more information, and it's a very fast scan. So you can get all your information just with one scan. So I think this is the way to go with time. Though it's much more expensive, I think it probably costs 3 times that of the Pentacam.
Also, do you find that if somebody has lens opacities, then your topography and tomography results are little skewed? So do you see the shadows of, especially in a dilated pupil, if you take topography or tomography, in a patient who has lens changes, do you find that you sometimes get more steepening seen or areas of irregularities seen in those opacified areas?
Basically the curvature maps are from the Placido disc. So the lens opacities have no influence on the Placido. And the elevation maps are from the OCT, ASOCT. And again, that has no bearing. See, the lens, you can image the lens, and where imaging the lens is important is for when you are doing your ICL calculations. If you want to look at the lens rise, it gives you the lens rise. And there are some formulae which uses lens rise in calculating Walt for the phakic IOLs, and there it is useful. But as such, if there are lens opacities, in the MS39 you don't have like a densitometry like the Pentacam. The Pentacam has a densitometry where you can objectively look at the density of the nucleus and then kind of classify it and then correlate it with the log scores for cataract. The MS39 does not have a densitometry, but probably in future, looking at the reflectivity of the scans there, B-scan there, they can also look at lens densitometry. That's the only thing that it doesn't have, the densitometry, even corneal densitometry.